welcome everybody. First of all, good morning, good afternoon, good evening, wherever you are joining us from around the world. Welcome to MOH by Sigvaris. We're delighted for you to come to the MOH talk today. I'm really excited about this talk personally. My name is Katie Stevens. I'm actually one of the clinical nurse advisors for the UK. And today we have this session on standardizing lipedema care, the German S2k Guidelines, recommendations and clinical evidence for nutritional interventions for lipedema. So this remains one of the most debated conditions in practice. So this webinar gives us a chance to explore the 2024 German S2k Guidelines, or the updates, including key changes in diagnosis and management, with a focus on compression therapy and conservative care approaches. We're also going to review the current evidence for nutritional interventions and their role in patients with obesity or metabolic comorbidities, alongside an update on liposuction following the recent approval by the German Joint Federal Committee. But one of my favourite parts of today is that we're actually joined, and I'm really honoured, by Dr. Gabriele Faerber from the Centre of Vascular Medicine, Hamburg. She's the coordinator and lead author for the German S2k Lipedema Guidelines, so I'm very honoured. Here at Sigvaris Group, our mission is really to promote global scientific exchange, and we invite you all to be a part of the conversation. So we've got a question and answers. Please use the chat box to submit your questions and comments at any time, and we'll address them during the panel discussion. If we don't get time to answer all of your questions, we will follow the answers to those questions up by email, so you will get an answer. But with that, it's also a great pleasure for me to introduce our principal moderator, Dr. Faerber. Allow me to share a few words about him. So he's consultant vascular and endovascular surgeon with expertise in endovascular and open procedures for critical limb ischemia, diabetic vascular disease, and complex aortic aneurysms. He specialises in hybrid techniques for PVD, varicose veins, and dialysis access. Dr. Faerber is active in surgical education, simulation and skills training, and has been published widely. And he also serves as an examiner for the Royal College of Surgeons of England. Don't know how you get the time. But he currently serves at the General Organisation of Teaching Hospitals in Cairo. So I would like to hand over to you, Dr. Faerber. Welcome.
Thank you very much, Katie. I'm really honored and delighted and pleasure to be in such a great webinar with my dearest Dr. Gabriele Faerber. She is a specialist in Filipology since 1990 and a specialist in lymphology since 1998. And she is qualified nutritional medicine and the clinical focus on lipedema. So we have a wealth of experience, 20 years in management, diagnostic and management the cases of lipedema, which is a wealth of knowledge and a wealth of experience. She is also author of international speaker in many vascular societies. She is eminent scientific board of German Society of Filipology, and she was on the editorial board for the most recent guideline from German Filipology, the S2k Filipology recent guideline. I'm really all ears, all eyes to your great lecture, and thank you very much that you're offering your vast experience in a field which is difficult to us. That is, mic to you, my dearest Professor Gabriele. You can start.
Thank you so much, Omar. Thank you, Katie. Thank you for the invitation. I'm really pleased and honored to be able to share my long time experience. It shows that I'm getting older and older because my experience is growing in years. So I'm just going to share my screen. Okay, that should be all right. Can you see everything? Good.
That's brilliant. We can see all of your screen. Shall we have the first poll question before we start? Just to check any understanding. Oh, and here it is already. So it's to identify the correct answers. So polls are a really great way for you all to be engaged before we start. So which answer is wrong? In this on the screen in front of you. If you just click the answer, and then it will give us the results. So lipedema is a chronic disease. There is no spontaneous remission. Lipedema is always accompanied by painful sensation in the affected regions. Morphological stages do not correlate with symptoms, severity, progression over time. Lipedema is always progressive. Compression therapy, like all therapy options, shall be directed towards the reduction of pain and other subjective symptoms. So which is the incorrect answer? We're just given 30 seconds on that, and we will see the answers. All right, we will cover those answers at the end. So Dr. Faerber, it's over to you.
Okay, thanks once again. It's impossible in the time allotted to me to give you everything that is actually important in the new guidelines. I'm focusing on the changes and on conservative therapy, and in the second part on nutritional interventions. And I also touch, as Katie said before, the new, what's wrong now? I can't, yeah, now. Okay, no conflicts of interests. Well, the first, why do we need guidelines? Why did we need a new guideline for lipedema? The goals of this guideline was to give an overview over the actual most appropriate and most helpful therapy options. And the background to that is that a lot has changed within the last 15, 20 years. And the reason why this is so important is that lipedema is a chronic, painful disorder, potentially limiting the quality of life of patients considerably. It might be very difficult to lead a normal life in advanced cases, and treatment also involves usually high costs for patients and healthcare insurances. It represents a considerable economic burden and social medical relevance, and pain and weight gain cause a severe deterioration of quality of life and have negative effects on mobility, function, mental health, and social interactions. And so everything that we do while trying to treat those patients is meant to improve the quality of life and the symptoms of the patients. So what are the fundamental changes? In the old guideline, which is now more than 10 years past, was published more than 10 years ago, lipedema was still considered a disease characterized by edema. And so treatment of edema, CDT, was paramount. Now, this has changed considerably. Now, the pain is at the foreground. Lipedema is a painful, disproportional, symmetrical disorder of the subcutaneous adipose tissue in the extremities. That's the main difference at how we look at the disease by now. So, as I said, all therapeutical measures aim at reducing pain and other symptoms. So the definition is painful, disproportional, symmetrical disorder of adipose tissue in the limbs, and it is only encountered almost exclusively by women. In the guidelines we stated, and this is slightly seen differently in various countries, it affects only legs, including the gluteal region, and arms, reaching up to the shoulders. It doesn't affect head, neck, trunk, or any other part of the body. Hands and feet are always spared. If there is a symmetrical accumulation of subcutaneous adipose tissue without any symptoms, it is not lipedema, it is called lipohypertrophy. That's an important distinction. Also, very importantly, lipedema is not caused by obesity, nor does it cause obesity. It's often looked at as once you gain weight, you'll start your lipedema. That's not true. Unless there's a genetic disposition, weight gain doesn't cause lipedema, and lipedema doesn't cause obesity. Of course, we have quite a high number of patients with two diseases. Obesity is then a coincident disease, but this coincident obesity is proportional, affecting the trunk also. And notably, obesity can cause secondary lymphedema. There is no evidence for lipedema itself being the cause of secondary lymphedema. In almost all cases, it's weight gain that causes this. Unfortunately, there are still no technical or lab tests for the verification of the diagnosis. So we still rely on clinical diagnosis, and that means we have to examine the patient in person, and we have to look at the medical history, all possible coincident diseases. We inspect the patient, and we have to perform a comparative palpation of the legs or the arms and the abdomen. It's called palpation because it's not a good idea to pinch. Pinching at some point is always hurtful, but it's palpation to recognize the sensitivity. So pain and symptoms, as I said before, it's always accompanied by painful sensations, and this pain can be on pressure or even touch. There can be spontaneous pain, and very, very commonly feelings of heaviness, congestion or swelling. And of course, perception of pain tolerance varies considerably between individuals. So especially the pain on touch or on palpation cannot be objectified by any examiner. What we can do is, within one individual, within one patient, we can use NRS or visual analog scale to document changes in the course of the therapy. But we cannot compare those NRS or VAS scales between different patients. So if we have a quick look at the US standard of care, which was published in 2021, we can see there is a lot of agreement between us. There are a few differences. Painful tissue, not always. We say it must always be some sort of pain. If there's no symptom, no pain, it's not lipedema. And then we exclude the abdomen. In the States, abdomen can be affected. And recently I heard a talk by a very eminent lymphologist in the States, who now says it can even affect other parts of the body, right, more or less everywhere. This is something that we exclude. The clinical appearance is, as you see here, there is increased adipose tissue in the extremities, and there is usually or very often a marked step adjacent to the, for instance, ankles or knees. At the ankles, it's called a cuff-like appearance. This is not necessarily so. There are patients who don't demonstrate this, but it's a typical sign. And also on the arms, it's the triceps region in the upper arm, which is very often heavily affected. We don't think that the so-called nodules are very helpful for the diagnosis. This is another difference to the American standard of care. And most importantly, the morphological picture does not allow for any conclusions on the subjective symptoms. I'm going to show you examples for that. Standard of care US, on the lower abdomen, it's included, and the nodular or fibrotic, the nodules are very important for the diagnosis there. They are not here, not according to the GEM guidelines. And as I said before, pain is more or less mandatory. So these are examples for the stages, the morphological stages. Stage 1, stage 2, more it becomes more pronounced, the changes in the skin. And on the right-hand side, you can see a stage 3 patient with secondary lymphedema, which you can easily see at around the ankles above the feet. And you can also see that this lady is heavily obese. So once more, the recommendations or the classification and staging, it's meant to be descriptive, morphologically descriptive, and shall not be understood as a classification of severity. And there has not been developed any staging by the severity of painful symptoms. But it's often said we abolished the stages. No, we did not, because we still need them for ICD coding. ICD stage 1 lipedema is E88.2, and so on. You can see here stage 2 and stage 3. So we have to use the code still. So but it's purely a morphological description. As you can see in this patient is a young student, 19 years old, normal BMI, extremely narrow waist height ratio 0.38, which is almost underweight. She gives her pain, according to the NRS, as moderate 4 to 6. Really, she has severe symptoms which affect her while playing sports. She cannot ride a bus on cobblestones or cycle on cobblestones because she has experiences extreme pain. So the morphological changes do not correlate with the subjective intensity of the symptoms, nor with progression. And it's absolutely possible and actually very common for stage 1 patients to have a high pain score. Lipedema is not, that was one of the questions or the answers, the possible answers in the poll questions. Lipedema is not categorically progressive. It can stay stable, the disproportion can stay stable over decades. Volume increase is correlated with progressive weight and, as a consequence, very often decreasing mobility. As you can see again in this picture, the lady on the left is 52 years old. She has had stable lipedema for 30 years, whereas the lady on the right is very obese and has progressed to stage 3 in legs and arms. Very importantly, again, obesity can cause secondary lymphedema. It is obesity which normally causes it, and the progression of the painful symptoms, on the contrary, is not correlated with the extent of the disproportion or the increase of the volume. But the symptoms can progress, can be triggered by a variety of factors. Very often it's hormonal changes, also psychological stress and compromised mobility. any therapy can reduce pain, but there's no spontaneous remission. And once you stop the therapy, the pain will come back. So another recommendation, it's not categorically progressive. And if there's progression, you have to investigate how progression happened and what were the causes of it. Also, very important, it is not possible, not useful to classify lipedema patients by BMI only. This is why we have to document various biometric measurements at the first examination. And at least this is weight, height, waist and hip circumference. And we strongly recommend using the waist height ratio, waist circumference divided by height, because BMI alone is not a robust means of characterizing overweight or obesity. I have sometimes patients with a BMI of more than 35, 37, 30, almost 38, with a perfectly normal waist height ratio. And we published that a few years ago, following up more than 600 cases. And you could see that classified by BMI, a lot more patients were classified as obese than classifying them by waist height ratio. The normal waist height ratio, why is that the case? Because, of course, waist height ratio is independent of the total weight of the patient and also independent of the weight of the extremities. Normal values are below 40 years, below or equaling 0.5, and after the age of 50 years, it can be up to 0.6. So since pain is the leitmotif in the guideline, all therapeutical options measures must primarily aim at reducing pain. And the indications for any therapy it does not depend on stages. It's independent of stages because the treatment goals are the reduction of symptoms and, very importantly, maintaining or regaining mobility, functionality, and quality of life. So that applies, and that is my focus today on compression therapy, also IPC, physiotherapy, nutritional therapy, and of course for liposuction. So there are a number of recommendations concerning compression, and in lipedema, compression aims at pain relief, at reducing the symptoms, and compression can, especially at the beginning, be applied by various compression methods. We can also use MACs at the beginning, but for long-term treatment, medical compression stockings should be preferred in routine cases. You have here two examples for MACs and one example for a multi-piece compression hose. So compression therapy shall be directed towards the reduction of pain and other subjective symptoms. But of course, if lipedema is combined with edema of any other cause or origins, compression therapy may also have a beneficial effect on the edema. So what kind of compression do we recommend? In principle, we can treat lipedema by either circular or flat knit compression stockings, but as you can see in this picture, it would be absolutely impossible for this lady to wear round knit compression stockings. So as a general rule, flat knit quality shall be prescribed for limbs with large changes in the circumference or a conical shape or deep folds of tissue, since in those cases, round knit stockings will cause even more pain than before, because they are just not able to fit on these legs. So generally, in most cases, flat knit stockings compression is mandatory. There is no fixed assignment of compression class. The best material that helps the patient, that reduces pain and symptoms, shall be used. And because lipedema does not affect the feet or hands, you can also consider leggings, which in the summer are very popular with patients, or in cases where there is pronounced obesity, a multi-component compression is more appropriate because it's easier to don. And also, I think it's not fair, it's not appropriate to tell patients that compression will reduce their adipose tissue, nor does compression prevent progression. If there is progression, there are several reasons for that. For instance, weight gain, but compression. If a patient, it must be made clear to patients that it's the relief of symptoms that is the goal of compression, and not the prevention of getting more volume. This will depend on different factors. So flat knit material is independent of stages, but of course, as you could see, any stage 3 has to be prescribed flat knit material, because it's impossible to use round knit stockings. This is an example. This was even flat knit stockings, but it shows how it doesn't work. And the next picture shows what we did and how it did work in the end. And the patient was highly satisfied afterward, and had really less pain and could move more easily with the compression. Of course, there is intermittent pneumatic compression, which is very helpful, also for pain relief. And it's an important tool for self-management, because patients can use it every single day. And in lipedema, not in lymphedema, in lipedema, it may even replace, or very usefully replace, MLD. So what about physiotherapy? Physiotherapy does not consist of manual lymph drainage. This is more passive physiotherapy. We can use MLD, especially at the beginning, for reduction of symptoms, because we know that the MLD can increase pain threshold and pain tolerance. But it's only useful in combination with compression. Otherwise, the effects will be gone within a few hours, if not minutes. And the best way is to exercise in compression, or to use water, aqua cycling, aqua jogging as exercising. Why is exercising beneficial? As we all know, exercising can reduce stress. It has antidepressant effects, and it can also reduce inflammation. So we are coming to the end already, almost. Another way to reduce pain, of course, is liposuction. And liposuction shall be regarded as the surgical method of choice, for sustainable reduction of the affected subcutaneous adipose tissue in the legs and the arms. And the indications for liposuctions are refractory pain, no improvement or hardly any improvement by conservative therapy, but also complications such as reduced mobility and dermatological or orthopedic conditions. Not dependent on any stage. All stages can be treated by liposuction, or should be treated by liposuction. And the decision by the General Federal Joint Committee, the 2025 decision, has now come into force, and the regulations are such that there is a 4 eyes principle. That means that diagnosis cannot be made by the doctor who operates later on. There are certain expert groups, doctor groups that can diagnose it. The prerequisition one is a stable weight for 6 months, especially in the range above 30 BMI. The committee followed us, the guidelines, unfortunately only up to a BMI of 35. As I said before, this can sometimes be not very appropriate because some patients have a BMI over 35 but have still normal waist-height ratio. But at the moment, the rule is that above a BMI of 35, liposuction is not possible and obesity treatment must come first. As I said, with a normal waist-height ratio, there is no obesity. Conservative treatment has to be undertaken for 6 months, and then the patient is referred for liposuction to a plastic surgeon, dermatological surgeon, or other surgeons. So liposuction is available on public insurances in theory, but reimbursement is cost covering at most at the moment. And we'll have a long waiting list. In our center, liposuctions are performed on the public insurance, but it will have to be seen how many patients we can treat in which time. So there will be long waiting lists. So this is the end of part 1, and I'm awaiting your questions with pleasure. Thank you very much.
That is excellent. Thank you very much for a great lecture and a great update. I really enjoyed every second of it. And here is the answer to the first poll question. Do you like to comment on it, Katie?
Yes, so we're just having a look at these answers coming through now. So I wonder if the answers would be different after the presentation. So with 40%, they said the correct one, lipedema is always progressive. So that was the largest answer. And then the other ones, there was one at 36%, which was about the morphological stages do not correlate with symptom severity or progression over time. So I think we have a great understanding. There's also a question in the chat. Are you ready? So the question in the chat says, what happens if these patients need knee replacement operations? Does lymphorrhea happen through the incision as a complication?
No, if there's no lymphedema and the operation is done correctly, there is no lymphorrhea. It might be, I have sometimes orthopedians who are planning to operate on knees or knee replacement. They recommend sometimes to have liposuction first because it's obviously easier if there is a lot of fat tissue, adipose tissue around the knee. It seems to be easier to operate on. So this has to be decided on a case by case decision.
Absolutely. And another question. So for compression therapy, which is better, short stretch bandage or Coban or MLD?
MLD on its own is no standalone therapy. It has always got to be combined with compression, as I said, because otherwise the effects will vanish within a few hours. Short stretch bandages is difficult. It's difficult to bandage a leg like the legs we saw. And the bandaging usually starts slipping within a very short time. So that is why we recommend possibly multi-piece compression, like sort of Bermuda shorts and thigh-high stockings underneath. If it's difficult to don them, which is the case for many patients when they are obese, but compression is always compression stockings are always to be preferred.
Thank you. And Dr. Al Farouk, did you have something to add to that?
Yes, I think there is a question came on the chat. Why is there is a difference between United States and Germany guideline regarding central adiposity?
Yeah, that's a good question. I can't answer it. Maybe, I mean, there is no evidence for abdominal adipose tissue possibly being qualified as lipedema. The main difference between lipedema, subcutaneous tissue, and other subcutaneous tissue is pain. And of course, if I pinch very hard, as I said, at some point, it feels very unpleasant. This is just according to the available literature. I know I can't explain it to you. It's maybe it's also to do with the even higher number of obesity or proportion of obese patients in the States. I don't know. We don't treat it. We don't. I mean, of course, you can have liposuction on your abdomen, but this is aesthetic procedure, not lipedema therapy.
Excellent. And one question that come to my mind before we jump into your part two, regarding the governmental reimbursement for liposuction, the new decision after S2k, do you think this will affect the number of liposuction cases done in Germany? Do you think this will have an impact?
Yeah, it will. It already has. We are flooded by patients who probably up to now thought it's not worth getting the diagnosis because they couldn't pay for the operation in the first place. And also because there has been a lot of reports, and it's been in all media. So there is a far higher awareness, which is good, but it's difficult for instance, for us, our center. We are the biggest, the largest center in northern Germany, and we can't cope with the numbers. And I know of many other colleagues where it is the same. But certainly awareness has grown, and many, especially at the moment, I have a very high proportion of very young, slim, normal weight patients with a high pain score. Not so much the stage 3 older patients.
Yeah. Okay, thank you very much. We have multiple questions on the chat, and the question that we're not able to answer live, we'll send the answer by email to this candidate. Do you like to add anything, Katie, before we go to part two?
No, that's brilliant. Let's go with part two. We want to stay on time this evening. So, yeah, but we will answer any questions at the end of the session via email, just like Dr. Elfrich said. So, yeah, looking forward to part two. Yeah,
so the mic is back to you, Professor Gabriele, for the part two of your great lecture.
Thank you. Okay, so I'm proceeding with the recommendations given in the guidelines, and then I go on to give you some clinical evidence and evidence from papers that have been published recently. Again, there are quite a few general recommendations, which is important, I think, and all those recommendations were met with a very high agreement, and the nutrition and weight management, if that is necessary, shall always be used to help patients maintain or regain, again, we've got this term again, mobility, functionality, and prevent the disease from progressing. Aims shall therefore be achieving or maintaining a healthy body composition. I'll explain what that is, as well as the reduction of pain and other symptoms. So it's not all about weight or losing weight. It's about reducing symptoms, improving quality of life. Of course, if overweight or obesity is present, the treatment of that shall be included in the overall concept that is to be taken for granted, because it causes deterioration of the total situation. Focus is not on weight, but on a healthy body composition. And healthy body composition is characterized by a good balance between fat mass and fat-free mass. So now you might say, of course, a lipedema patient with a lot of adipose tissue on her legs will always have an increased fat mass. But we have to look at the fat-free mass. We have to preserve the muscle mass. Because this is even in lipedema patients, it's a common problem that muscle function is not quite as good as we wanted. So lifestyle and eating habits, we know now, do influence lipedema pain and progress. Pain also. It's not as it used to be looked at in earlier days, that you can't do anything. Lipedema is your fate and you can't do anything against it. So what can we do nutrition-wise? We have to provide the patient with sufficient protein in order to prevent a reduction in energy expenditure or basic metabolic rate, and to facilitate sustained weight loss, and that has to go together with moving, with exercising, especially because, as I hinted at before, sarcopenic obesity is not uncommon in lipedema patients, and it must be recognized and treated. At the very end of my presentation, I'll show you 2 examples how we do that. So patients shall be informed early on, educated early on about the possible cause of their disease, about the negative impact of obesity and the significance of a healthy diet and an active lifestyle. It shall be made clear to them that they can do something themselves. They are not helpless. They can take their lives and their disease into their own hands and help it to stay stable over a long time. That is why one must avoid short-term diets, because we all know short-term diets will result in more and more weight gain afterwards. The goal is to adapt the personal eating habits permanently to a healthy and individually tailored nutrition. Then, of course, if weight reduction is necessary, in the case of coincident obesity, it shall always be, and that is a general recommendation also by obesity guidelines all over the world, a combination of nutritional measures, physical activity, and, if appropriate, behavioral therapeutical measures. And very importantly, include the weight reduction phase and long-term stabilization. And it would be good even for colleagues who diagnose lipedema for the first time, or for the patient, it's the first time they get a diagnosis, that they understand that eating habits have effects on their disease, because they affect blood sugar and insulin levels, and therefore affect the degree of building up adipose tissue and inflammation. High insulin levels promote lipogenesis, more fatty tissue, and promote the retention of sodium and water. And even if lipedema is not primarily an edema disease, of course we can observe more or less retention of sodium and water. I'll show you later on in my last 2 screens how this can be shown. And high insulin levels have pro-inflammatory effects. Hyperinsulinemia per se is an inflammatory state of, it shows all the symptoms of inflammation. So this is why you have to prevent, as a patient, you have to prevent spikes of blood glucose and insulin. And one of the methods to do so is to avoid eating between meals and to observe sufficient intervals between meals. Like, you all know probably about intermittent fasting, which doesn't have to be 16 hours versus 8 hours, but it would be good, or it's very good, to keep a long fast overnight, so the insulin can go back to normal. There are two specific diets which have a recommendation in the guidelines. The first is a so-called Mediterranean diet because it addresses inflammation and focuses on fighting silent inflammation, and also by adhering to such a diet, you become aware of what increases inflammation, pro-inflammatory triggers. The second recommendation is on a ketogenic diet. And this one may be recommended because we have weight reducing and anti-inflammatory and therefore symptom reducing effects. And this is my experience, has been my experience since 2008, when I started treating my patients by using a ketogenic diet. I had no idea what was going on at the time, and I was completely bowled over by the reduction of pain once the patient started following this diet. I'll come back to that later. Once again, if you decrease your insulin levels, you reduce inflammation and you can reduce your weight. And in a ketogenic diet, there is one really important ketone body, which is called the beta hydroxybutyrate, and that is a very strong anti-inflammatory agent because it blocks inflammatory reactions in the body. And also ketosis reduces retention of fluid and sodium because it reduces insulin to a very strong degree. Interestingly, for the first recommendation, there was a strong consensus, although in lipedema there is not that much of evidence, whereas for ketogenic diets, the evidence is growing steadily. There have been quite a lot of RCTs recently, which I am going to lead you through in a minute. This is the first group in Poland, a Polish group that looked at the effects of a low carbohydrate, high fat diet versus already a modified diet versus a moderate carbohydrate, moderate fat diet. And they looked at body composition, leg volume, and lab values, and of course, body composition, leg volume, and pain. And I'm going to show you, I summarize the results. The ketogenic diet was superior concerning everything: body weight, fat mass, circumferences of all circumferences, waist, hips, thighs, legs. It improved the disproportion slightly better than the low fat diet, and it improved pain, edema, mobility, and quality of life. Notably, the glucose profile, liver values, HDL, inflammatory markers were improved, but there were no negative effects on thyroid or kidney functions to be found. The other very active group is in the north of Norway, in Trondheim, and the group around this young scientist, Julian Lundanes. They again looked at pain and quality of life. They looked at the degree of reducing subcutaneous adipose tissue, the gastrointestinal hormones, and subjective, very importantly, subjective ratings of appetite. And they looked at cytokines and fibrotic growth factors, and they compared a low carbohydrate or a low fat, low energy diet. So both diets were calorie reduced as far as calories were concerned. It was a 1,200 calorie diet, and it was over 8 weeks. And again, they looked on pain, quality of life, on the effects at the effects of pain, quality of life, weight and body composition, inflammatory markers, and satiation versus hunger. And again, the findings were low carb ketogenic was superior concerning weight loss, pain reduction, reduction of calf circumference and subcutaneous tissue in the calf. That was a small sub-study. They used MRI for that. That was a very small sub-study. Satiation and hunger improved, and inflammatory markers like AS-CRP, TNF-alpha, interleukins were also reduced. Although this is difficult to understand, it maybe takes too much time to try and explain it, but there was no correlation individually between the two, but on the whole, you could observe a reduction in inflammatory markers. This is my modest beginnings in 2017 when I published my results. And I looked at patients, about 100 patients with lipedema, and we document the symptom severities before and after the therapy. And as you can see, the severity decreased by almost 70% directly after the therapy. And then we after a follow-up of more than 3.5 years, it was still improved by more than 53 degrees. So this is very early on. It's retrospective, but recent RCTs have confirmed that. So what can patients eat on a ketogenic protein optimized diet? This is my special term, because I think it's not only the ketogenesis or ketosis, it's also important to provide the patient with enough protein. So generally we keep carbs below 50 degrees. And protein has to be between 1.2 and 1.5 per kilogram reference weight, not actual weight, reference weight. That is the recommended amount of protein, which is now generally recognized. There is always a debate about fat. Is a ketogenic always a high fat diet? That is not the case. It depends on the goal. If you want to lose weight, you mustn't be afraid of healthy fats. We need them. We need healthy oils, but we have to reduce the total amount of energy we recommend the patient because they want to lose weight. If there is, as I have many patients, as I said before, if there is a completely normal weight, slim patient, and she wants to improve their symptoms, she has, of course, to get enough energy so she doesn't lose even more weight, and that means she can use fatter cheeses, everything that she likes, in order to get her calories in. And of course, you can or you should vary your sources for protein and fat to try and get them as anti-inflammatory as possible, which is why in most cases I recommend omega-3 fatty acids. There are two ways how you could approach as a patient approach this kind of diet. You could try and start slowly. In that case, you would reduce or better omit sugar, refined carbs, and highly processed food, especially those. Well, normally they all contain a lot of additives, and that it's important to avoid them. Try and eat whole food, preferably self-prepared. It's not always possible, but try to get whole food and not ultra-processed one. Fill up on veggies and protein. Don't eat for 4 to 5 hours between meals. No grazing to keep your insulin down or low. And then you can consider further reduction in carbs towards very low carb or keto, but you can also you might already observe an easing of symptoms without having to adhere to a strict eating plan. Disadvantages, in many cases, cravings persist, especially for sugar. Also, there's this term food noise, which many patients tell me they experience. This might still be the case in this slow start. So in my practice, I usually advise patients to dive straight in, because then it's two or three unpleasant days, maybe, but after that they are stable and they feel wonderful. So in that case, carbs below 50 grams a day, breaks again between meals for at least 4 hours. And then during the first 2 or 3 days, when they are not yet used to the diet and they might crave for bread or sugar, they can eat to satiety. They don't have to lose weight in the first 2 or 3 days, but strictly no extra carbs. Don't fall back on the former eating habits. Eat sufficient protein, lots of low-carb vegetables, drink plenty of water, preferably mineral water, or maybe use electrolyte supplements, because you will lose a lot of water. We can observe that, and with the water you lose sodium and other electrolytes. In my opinion, especially if you do it the first time around, a ketogenic diet should always should preferably be conducted under clinical medical supervision, either by a healthcare professional, a dietitian, who knows what to do. And I think it's also important, excuse me, to check for, to have a profound lab test at baseline for liver and kidney values, thyroid, cholesterol, most importantly, insulin resistance, that's the HOMA IR, HbA1c, ferritin and vitamin D. More or less everybody in Germany or northern middle Europe is deficient concerning vitamin D. And we also have to manage medications. We have to reduce most medications in the course of the therapy. And very importantly, we monitor body composition to detect and to treat loss of muscle mass, which is absolutely something that must be avoided. So what kind of supplements do I use? As far as vitamins are concerned, vitamin D is almost routine. They all need it. Other vitamins if necessary, but in a very balanced diet with lots of vegetables, you might not need extra vitamins. Electrolytes, as I said before, depending on symptoms, if there is a headache, especially during the first days, you can or should supplement with sodium, potassium, magnesium, and omega-3 fatty acids, because it's still debated, but we think that lipedema is a disease characterized by low-grade inflammation, and so it is always good, and especially if there is coincident obesity, one should try and change the fatty acids that you consume, the patients consume, and that's why I recommend 2 grams a day at least. If there is higher inflammation like CRP above 3, 4, 5, I start them on 3 to 4 grams a day. So what are the metabolic effects? We can achieve stable low levels of glucose and insulin, which we document, monitor. We can increase diuresis and natriuresis. That's something to be watched because patients lose a lot of fluid. We reduce omega-6 fatty acids, so we reduce inflammation by that. We reduce aromatase, which is an enzyme that causes estradiol to be built in adipose tissue, in subcutaneous adipose tissue. And we know that in lipedema, there's a lot of subcutaneous adipose tissue, and So there's quite a lot of estradiol, and we know that there is a hormonal connection. Estradiol plays an important role in manifestation in the phases when lipedema manifests itself. Interesting, we experience or observe cortisol levels reduction, stress reduction, and cortisol again is can lower pain threshold. So if you lower cortisol, if you decrease cortisol, your pain threshold will increase. Reduce pro-inflammatory agents. As I said before, there is one which is called AGEs, advanced glycation end products. That's end products by the metabolization of sugar and other carbohydrates, and this is very inflammatory. It's also nowadays recommended to reduce them in the case of neuroinflammatory diseases. So it's important to avoid those. And again, beta hydroxybutyrate blocks pro-inflammatory immune reactions. So all these are effects that we have evidence for that. And now I'm going to show you two patients of mine. This young lady, 34 years old, had lipedema stage 3, and within the course of slightly more than 12, 13, 14 months, she reduced her weight by 20 kilos. Her waist height ratio became almost normal. She was in my practice because she wanted to have a liposuction, and she was then operated on. And as you can see, it's a bit difficult to see, but the arrows show you the worst value. This is a bioimpedance measurement, and it shows you the distance from that line. The vertical line shows you the muscle mass decrease or increase, and as you can see, we started off. This is number 1, number 2. And that was the last one before she had the operation. And this is just to show you that this is a very good means to not only show muscle mass or hydration, increased hydration, but also here, this was immediately after liposuction, when she was still full of water and inflammation. So that was the worst value. But she increased over time. And the next patient lost even 45.6 kilograms, again in 15 months. And you can also see that those are her measurements. She slowly increases, climbs up, becomes less overhydrated, and is in the normal range here. And she too had liposuction after this nutritional intervention. So what are my take-home messages for a nutritional approach in lipedema? There's certainly no one-size-fits-all solution, but an initial ketogenic, I call it a reset phase, to manage weight and symptoms can almost always be recommended. There are hardly any contraindications. And then for long-term sustainability, one has to try and find out the individual tolerance of carbohydrates and which carbohydrates are tolerated, which are not. And then I must say that lipedema patients are very sensitive. Normally, we can add pulses, we can add veggies with a higher carb content, but normal bread, especially white bread, will always cause symptoms to come back. The aim is a metabolic flexibility, so switching between very low and moderate carb consumptions, which will allow for alternating phases, for instance, on holiday or whenever it is wanted. And a well-formulated ketogenic diet can reduce weight and volume of extremities, have anti-inflammatory effects due to the reduction of those AGEs. Insulin goes down, beta-hydroxybutyrate, as I described, decrease of pro-inflammatory agents, cytokines, decrease retention of fluid and sodium, reduce edema, and above all, and most importantly, it can decrease lipedema symptoms such as pain, feelings of heaviness, and congestion. And that's the end of part 2. Thank you so much. And I think we have one more question. Poll question.
Yeah, that was brilliant. That was so good. But yeah, we do have another poll question. So that should be coming up on your screen now. So which answer is correct? So nutritional interventions aim at achieving or maintaining a healthy body composition, as well as a reduction of pain and other symptoms. Treatment of overweight and obesity, if present, shall be included in the overall concept of lipedema treatment. Lifestyle and habits considerably influence lipedema pain and symptoms, as well as progression. A ketogenic diet can help reduce weight, inflammation, edema, and symptoms. Or the final option, all answers are correct. Let's see what you come up with.
Excellent. I think in the time of 1 minute to get the reply, I would like to have also the take-home message from my co-panelist, Katie, which you are treating a lot of lipedema cases. I was impressed with Professor Faerber lecture. What's your take-home message for our practice, Katie?
Do you know one thing that I felt really interesting, talking about the nutrition, I really feel like all of us should be looking at that type of diet, you know, to reduce inflammation within ourselves. So that really hit home for me too. But of course, I've never heard anybody speak in such detail about the guidelines, and you really brought them to life. We all do a lot of reading, but hearing them from yourself just made me look at everything so differently as a practitioner, you know, that I see lipedema patients. So it just really made me feel very empowered actually listening to you today.
Oh, that's great.
It was amazing experience. I really enjoyed a lot of it. That's why a lot of the audience asked, when is the recording, when we'll see it, and it will be recorded and will be on our website. I think Professor Faerber, you really summarized to us 20 years of very valuable experience. To me, I also realize that stocking still is a golden standard. And in my practice, it seems liposuction will be increased. And one last quick question. Do you give compression after liposuction in your practice, Gabriele?
To start with, certainly, it's most important after liposuction for the first weeks. And then we have to try and slowly decrease and see how it goes. The aim, the goal of liposuction should be for most patients not to have to wear compression anymore. Sometimes it's not easy. Some patients are so used to wearing compression that they feel deprived if you take them away. Most of them will love that they maybe can go down from flat knit to round knit, or only knee-high ones, or or not wear them at all.
Yeah, I think with circular knit, you get more choice, don't you? You know, you have your flat knit garments, but there's so many different ranges to choose from. That personal choice comes into it a lot more. You know, we see like these full body garments. You know, it's not easy to wear that and put that on every single day. That takes commitment to do that. So if we can support patients with getting it on and off and giving them choice too, I think that's a real win too.
Excellent. So you can see the result of the poll. Brilliant.
Good.
Brilliant. 92% all the answers are correct. When I first started reading it, I was a bit worried. I was like, these all sound right to me, and then thank goodness the option came up at the end.
Yeah, I think it's a summary. It's a summary of the second part of my presentation, the various options. So I'm quite pleased that so many choose the right answer.
Okay. Thank you very much for a fascinating lecture and fascinating time. And apologize for a candidate who have sent some questions and were unable to answer. I promise them we'll answer them by email. And very nice take-home message. I really appreciate you squeezed 20 years of experience for us in 1 hour. That was amazing. And back to you, Katie, if you have any comment or we finalize.
Again, well, thank you both for being here on MOH today. It is a great platform for sharing, all the latest medical evidence-based practices. We all do have lots of different resources too. So in our LinkedIn and our YouTube channels, we try and share the most up-to-date evidence-based practice so that the patients out there get the very best treatment. So please follow us on our social media, our LinkedIn pages. Make sure you subscribe to the newsletter. I think the link was in the chat then. And just thank you once again for your active participation, all the questions, and look forward to seeing you on our next MOH session. But then until then, stay safe and goodbye for now.